Good afternoon, everyone. Oh, it is much better now. So thank you for coming to this panel session. I think that people are still recovering from the magnificent presentation of Al Gore. So they are recovering and they will join us later. But I think that this topic also deserves the plenary session. Let's make it fascinating now to deserve the plenary session next year. So I'm also thanking our participants for accepting this challenge to talk about such futuristic topic like future of medicine, genetics, and health. But although many of these things are really science fiction for most of us, we are creating it today for the year 2030. So our small decisions today make a great impact on what will go on for the following years. So be prepared immediately for the 2030. This topic has so many small issues that we could raise today, but we don't have time. So we will have several presentations, short presentations, and I'm asking you to prepare the best possible questions for our participants. So it ranges from the very practical things and open science and charities on the one side to patenting genes and ethical issues and even existential risks on the other end. So we will try to start with practical things and to end with the biggest dilemmas. You will be the judge if we are going to success. So I will invite Gino Tubaro, inventor who is helping thousands of young people to get artificial arms and hands with the help of 3D printing. So please tell us, how do you do that?
Don't you mind if I go standing up there? Thank you. It's better.
It's better. You can hide your notes and things.
This is the product, so take it out and pass it on. Okay. And I forgot the clicker. So, no, it's the clicker, I forgot it. Okay. So, pass it on, Don't forget it, pass it on. So, what we do in Argentina, we are helping kids to be superheroes, but not just a normal superheroes. I don't know, you know 3D printing? Have you ever seen 3D printers? Fairly? Okay. So when I was 16, I assembled my first 3D printer. And I say, okay, I can do a lot of things. I can print toys, I can print something for my inventions. And then I say, okay, I have to do something that really help the people. When I was 16, I met Felipe. Felipe was like 11, 10 years old. And the mom of Felipe, she asked us for a 3D printer. She says, hey, my kid without a hand, and if we want to pay for prosthesis, we have to pay more than $50,000. That's the situation in Argentina. So we started printing that hand, the hand of Felipe, and after a few days, he was fishing. He was using a fishing rod. And that was our first motivation to start projecting our big project. So to know the problem in Argentina and every part of the world, nowadays we have more than 50,000 users inscribed in the platform where they ask for a prosthesis. Imagine if they have to pay for a prosthesis more than $50,000. So each of them, they need a prosthesis, and we started to create a project. But first of all, you have to know the problem. So each prosthesis is really expensive. They have fixed sizes, so you cannot, if you lose a finger, for example, you need something special for you, and that's increased the price. Every prosthesis takes more than 6 months to create, and they only have one color. And what we are doing, it's less than $10. We make it customizable for those who want to have a hand, but it's also, the solution is more related to how we created it. So, for example, the short way to understand this is you only take a picture of your stamp. As you see in the first step, you take just a picture of your stamp. Then you choose if you want to have a superhero hand, or you want to have a football team hand, or whatever color you want to have it. Then you choose where you want to print the prosthesis. So if you are in Argentina, you can get printed by someone next to you. But if you are in Dubai or China or every place in the earth, you can download the files and you can print it. Everything is free. Everything is shared in the internet. So you can have, for example, a Batman superhero hand. Let's see some of the examples of what we have done so far. This, the first one, the eagle foot, for example, was printed with the same technology. Every prosthesis is created by a code. You can code the prosthesis. It's not more a normal design. So, for example, you run a Facebook page. When you go to Google, for example, you are running a website. So in this case, you are running a design. So you put the sizes of what you want to have, and then the page takes care of it, and then create the prosthesis in just a minute. So this guy was playing the Verbic with a 3D printed arm that was created with the same technology. And each of the arms take 12 to 20 hours to be printed. And we are doing this for free. We have already helped like 700
Turno.
kids
Brisa.
around the world.
Vamos. 1, 2,
This is
3.
something that I cannot.
¡Oh!
She grabbed a candy bar from the air.
Otro.
And she was also playing the
Anda
piano.
atrás, vos, colada.
And also
Ahora
they
esta
can
mujer
write.
argentina
So, for
realiza
example,
nuevas
this
tareas
project is
gracias a
really
este
based
diseño
on how the
innovador.
community
Uno de
helps
sus
to
sueños era
create the
escribir.
project to be
Hoy es un deseo cumplido.
more popular around the world. So there is a lot of histories. Those kids are ambassadors. They download the files from every part of the world. They download it, they print it, and then they help kids or elders to have a prosthesis. This is our map. Nowadays we have 32 countries and 7,000 ambassadors. And we are also working in schools, so we teach them how to code. Then after coding, they can 3D print the prosthesis, and then they learn about empathy. So for example, if you are now teaching the kids, for example, an hour of code, they just program a robot that is going to move in the screen. So with this idea, what we want to do is changing the way of how we think programming and do something useful for the community. So you program the prosthesis, then you 3D print, you learn 3D printing, and then you give the prosthesis for someone who needs it. And this is the eagle that is using the same technology as we do for humans. So there is a lot of things how we can do 3D printing. We can help a lot of kids. And there is also a challenge in the future. So nowadays we have a lot of things in savings, $5 million in savings, 7,000 prostheses in use. But what's going to happen in 2013? The idea and the challenge here is how we can help a lot of kids or people around the world using the less money, the less time, and being just helpful and not just having to pay a lot of money. So for 2013, what we want to do, what we project in the future, I'm just 22, but my idea of this 2030 is going to be everyone in the world will have a 3D printer that they will download some files, and then they will get the prosthesis in just a second. So this was in Christmas, so I hope that everyone in this world will have this kind of 3D printing solution. So the idea behind this is to invite you to teach your kids, to teach everyone that you know, or maybe if to get a 3D printer, that you can help someone for just $10 and just a couple of hours. Thank you.
For the next one, you saved us 57 seconds, so we can continue with something that was called Science Story of the Year in 2017. That is Arabian Business Startup of the year 2017. Here we have with us Bassem Hashash, who will tell us more about augmented reality platform.
Thank you. Okay, my name is Bassem Hashash, and I work for a company called Proximi. And what Proximi does is we have produced a piece of software or app that allows for something we call remote surgery. And basically what it does is it allows a specialist in a certain location to assist in a surgery in a far place, giving guidance and instructions on how to complete the surgery. The foundation of this technology is probably everybody know. It's basically called, it uses a live stream connection between smartphones, tablets, and laptops. But Proximi has added a small ingredient called augmented reality, or AR, as it is called these days. So what Proximi does is it falls into a category called telemedicine. And telemedicine, by definition, is something that uses telecommunication or data exchange systems like the internet to allow for collaboration. What we do, the focus these days in healthcare is on breaking down the barriers and using communication technology to make technology accessible, democratic, and more collaborative between different surgeons in order to provide healthcare to those that need it when they need it. Telemedicine is looked at as a futuristic thing. This is why we're here in this panel. So I'm here to talk about what, in our opinion, how medicine will be in 2030, in our opinion. The idea of remote surgery, of an expert surgeon beaming up his way into a surgery is quite futuristic. I don't know if people have watched a movie called Doctor Strange, and you see Benedict Cumberbatch, appear as a hologram to do a surgery. We are not that far from that these days. I mean, we're very close, and this is where everybody is getting in the future in terms of delivering the healthcare that's needed. Whether you consider telemedicine or not, I mean futuristic or not, we definitely, what we see as Proximi and what we're doing as Proximi is definitely future facing, because in global healthcare there are at the moment different challenges, and if they continue to operate in the same way, we're going to reach 2030 and look in a way not extremely positive. Okay, there needs to be change, and in order to make the outlook bright for healthcare delivery, what we're doing is we're using the technology to solve these challenges and maybe shape what healthcare looks like in 2030. I want, in the short time that we have, to explain some of these challenges. And you will know why Proximi, the idea of Proximi came. Proximi was co-founded by a plastic surgeon and a telecom engineer. A plastic surgeon that is very involved in NGO work, and at one point in time they found that they are not able to reach the needy areas to provide the help that these areas need for surgery. There is quite a shortage of specialists, surgeons, and healthcare providers in the world. I read a study that said that in the United States, there is a need to train an additional 100,000 surgeons by 2030, an additional 100,000, and this is in one country only. So can you imagine the need globally in the world? There is imbalance, definitely, in supply and demand. And a lot of studies have said that there are over 5 billion people worldwide who do not have access to the surgery they need when they need it. Okay? Because it's hard, it's hard for a lot of these people to go to a surgeon. They live in underdeveloped or poor worlds, and they cannot travel, and their location does not have the specialist they need. So rather than making them go through the cost and the expense and the hardship of being away from their community to go see a surgeon, what Proximi does is it brings the surgeon to them. Okay? So you have a case where a certain surgeon is not a specialist in a certain aspect of surgery. Very easy. He can seek the help of a specialist who can, through the application, through augmented reality, guide him on how to do the surgery. They can discuss the case, plan it, and perform the case together, rather than just by voice. It can be very intuitive, very visual, and they can deliver a safe and effective surgery through augmented reality or virtual reality or mixed reality. Okay? This is not only used for education and learning, it's about sharing and extending the reach of healthcare to wider areas. Definitely the world needs more doctors, like I said, and specialists. And the students that learn surgery, they need to learn it from a specialist also. And if they don't have access to a certain type of surgeries, they can seek, they can go to a specialist, attend his surgeries, and they can have the specialist observe the surgeries that they do, and give them an assessment on what they're doing. So what we're doing here is we're force multiplying healthcare and medical care. I believe that by the year 2030, telecommunication is going to be playing a major role in providing healthcare. More and more we're going to see people doing virtual consultations and clinical assessments without having to be in front of the doctor on a face-to-face. I think it already started. People are now able to
pay attention to the
translate.
time. Please pay attention to the times.
Okay. Let me start. I want to show a quick video to show you what we do with it. Some images may be a bit graphic. I hope it doesn't disturb you.
It's the brainchild of a surgeon who believes everyone should benefit from improvements in healthcare technology and is currently being used across 5 continents in some of the leading institutions. It is simple, practical and powerful.
My name is Nadine. I'm a reconstructive surgeon on the Pantams rotation. I'm co-founder of Proximi. I want you to imagine that by simply using a phone or a tablet or a computer, an expert surgeon could virtually scrub into any operating room anywhere in the world to visually and practically interact in an operation from start to finish. From marking up a patient to providing real-time virtual presence in assisting and instructing an operation from start to finish, overlaid with content, with augmented reality tools and patient data that will hopefully ensure that we're providing safe and accessible and cost-effective surgery to anyone in the world. That's the power of Proximi. Proximi is an augmented reality platform that allows surgeons to virtually transport themselves into any clinical setting around the world to collaborate and train.
One of the challenges we have really to teach students, medical students, is, in these surgeries we have a big team of, from anesthesia to nursing to the residents involved in the case. So There's restrictions in the operating room where we cannot have a lot of students to watch the cases. It's hard for them to see these surgeries. So basically one of the things we've done today is use the system Proximi, whereby the students were able to watch the surgery live and interact with the surgeon and the team here without being actually present in the operating room. So I think this is a major advantage of the system that we've got.
Let me explain why I'm now in scrubs. You see, we're at Watford General Hospital with a patient who's about to have a skin cancer operation, but the surgeon leading his operation isn't here. He's at another hospital over 15 miles away. Over at London's Royal Free Hospital, consultant Mr. Masabi is standing by, ready to lead the surgery.
This is my pen, which I'm going to bring in. This is the area of the cancer which we're going to remove. Yeah, Amira, I can see that. It's perfect.
It's helping train students at the Royal Free, and it's claimed it has the potential to speed up the NHS referral system, cutting the time it takes to get to see a specialist.
I think it was excellent actually, because I was looked after so well, and it was so not complicated. I'm in quite a bit of pain, and it was nice to be able to come to my local hospital.
Proximi, local where possible and centralised where necessary.
The potential for change is there. My team and I are growing our global footprint, and we're just starting to see the potential of this technology. Through digital technology, through simple everyday devices that we take for granted, through devices of the future, we can really do miraculous things. Thank you.
Yeah. I want to apologize. Something went wrong in the playback, so audio went faster than video on the computer. I don't know why.
Thank you, Mr. Hashash. So we are going with a different topic. So the human genome is mapped, but it didn't account for the diversity of human population. Is it a problem? It seems to be. And what we can do about it will tell us our next participant, that is Sumit Jamuar, who tries to democratize healthcare through genomics. There was a BBC talk about that, the power of 1 billion, and we had a review about that in MIT Technology Review. That is what global gene corporations does. So please tell us more about it.
Well, thank you. Good afternoon, ladies and gentlemen. Thank you to Your Excellencies, Chairman Waki and Mr. Vikas Pota for the opportunity to talk about the work that we do. And again, I'm delighted to be here with distinguished panelists and exchange of ideas. If we move to, what I'm going to do is just talk to you through a few pictures of what medicine looks like and what the vision of medicine should be by 2030. So if we move to the next slide, the point I'm trying to make, and in a slightly exaggerated sense, is that healthcare, unfortunately, is broken. And with more and more people coming in, and with the population growing, there's so much pressure on the system that it's not likely to get any better without technological disruption and innovative and smarter ways of doing things. So what does this chart say? This is basically just describing across different broadly drug classes, the percentages are what percentage of that drug is going to be effective in as a general point. So the world spends about $1 trillion on drugs, $1 trillion per annum. Of that, if you take a case like oncology, where we spend about $200 billion, in 3 out of 4 cases, studies have shown that it is not effective. So 75% of that treatment or that spend is ineffective. That is a big number. That is a huge number. And that number goes across different, if you go by disease category, that is what is there. And the reason is we are moving on a statistical based therapeutic development and healthcare versus a deterministic base. So it's not all doom and gloom, and this is where the work that we do and the work that we benefit from from our ecosystem, particularly in Cambridge, UK, is absolutely incredible. So what happens is think we probably need some assistance in. I think someone didn't like my remarks, so they've just shut my talk down. So what we wanted to do was, while this is happening, is I wanted to talk about this incredible thing called the DNA. And the DNA is basically the simplest way to describe it is it's the book of life, right? And I know it sounds like an exaggeration, but what it contains in the most simplistic terms are operating instructions for each one of us. It talks about external manifestation of whether I'm going to have black hair and brown eyes, or if I'm going to have blue eyes, etc. But it also controls and contains some instructions about what diseases I have propensity for. What happens if I have a particular disease, what treatment would be most effective for me as an individual. And I think that's incredible. That's an incredible promise. Just to give you a sense, the DNA, and I'm going to get into a bit of jargon, so excuse me for that. The DNA is 3 billion base pairs. What that means is that think of it as 3 billion points long. It's organized over 23 pairs of chromosomes that we inherit, one set from our father, one set from our mother. And across these 23 pairs of chromosome, we have 20,000 genes which are all organized. And that's the DNA. It's a tightly coiled double helix. Now, what we're trying to do is, that's a lot of information. So what we need to do is, we need to make sense of the DNA, we need to be able to write the DNA, we need to be able to analyze the DNA, and then we need to act on it. But what the DNA does is give us this incredible promise, which is the promise of precision medicine, which is to the right person, the right drug in the right dosage at the right time. That is a phenomenal promise, because it says it doesn't matter what your social strata is, it doesn't matter what your race is, it doesn't matter what your gender is. Each one of you will get the best possible treatment if we can understand what the details are. Why? And so going back to it, what are the enablers? The enablers which I talked about is, hey, can we write the book of life, and can we write it cheaply? The answer is yes. That curve from NIH tells you how much it cost. The first human genome was 1/3 of that was sequenced on the site we are based at the Wellcome Trust Genome Campus in Hingston. Costed $2.7 billion. Right now you can do it for less than $1,000. Those were big machines. Right now you can do it on this wonderful thing. This is a little machine in my hand. This can sequence a genome. This is by a company called Oxford Nanopore. It's elegant. It's amazing. Think of the same transformation that you had from mainframes to actually having things in your mobile phone. Your mobile phones are more powerful than the first mainframes. The second thing is, okay, we create this enormous amount of power. What can I interpret it? There's so much data. And the answer is, there are in enabling fields, this is a chart from Masayoshi Son, who is the CEO of SoftBank. And I love this chart because what it says is artificial intelligence has been 1 million times faster over the last 30 years. And it's going to be 1 million times faster over the next 30 years, which means that we have the compute power and the ability to make sense of all this. We have the infrastructure to be able to make sense of this data. Now we need to define what the problems we are solving for. And here's the problem. The problem is that 81% of the data, genomic data, currently comes from Caucasian or European ancestry. This is from Nature, and that is a huge problem if you think about it. Because what it means is, for most of us in this room, we do not have enough insight about what good looks like. We don't know what to attack if something goes wrong. And without having the right data and the right input, in science you cannot have the right output. And that is what is why it's so incredibly important to solve this problem of data and having the right representative data across the play. So we know populations are different. This just says that different populations have different, that's why it's important. So what we wanted to do today was, wanted to take the opportunity, and this is it is a great forum, that we have an ambition to sequence, to have 1 million people by 2022. And what I'm really excited by as I stand here today is that we have announced today a collaboration with a US pharmaceutical company called Regeneron, who are pioneers in genomics. to launch one of the largest sequencing programs across for Indian populations in India. And this is supported by Invest India, which is the Prime Minister of India's nodal agency for investment into India. And we are hugely excited by that, because what you need to succeed is a huge amount of support from the ecosystem, whether it's other players or others. I just wanted to highlight, because I've run out of time, so I'm just going to say this map is, our research says different states in India have different propensity for this. What this chart is saying, if you look at different colors, is Odisha has a higher propensity for a particular kind of mutation, which means that treatments which are there will not be effective. What we are saying is, but how you use that data is that you can then use the power of the app, which is the algorithms that we've built up, where you can actually, and this is something we're doing with Singapore Precision Medicine Initiative under Professor Tan, where you can have that insight translated into reality by actually putting in the drugs which work for you, or they don't work for you. So, you know, I put in something which someone like me is likely to be given warfarin sometime. You put in warfarin and you find actually it's not suitable for me because I have a particular mutation. And this is what the incredible promise of genomics is. And I want to bring together everything by saying why it matters and why education matters is you need to have the infrastructure. We need to create the jobs of the future, and that's what is needed for 2030. I want to be in 2030, when we look back, I want my son to look back and his generation to look back and say, you guys were so medieval. When you had a problem, you cut people up. You gave them toxic chemicals. You didn't even know if they worked. And look at us, it's so elegant. And I'm almost reminded of the scene from Star Trek where someone is suffering, in Star Trek Voyager, the doctor is going in and he sees a patient who's suffering from, and he says, what are you going to do? She says, I'm for dialysis. And she says, dialysis? Take this pill, you're going to be sorted. That is the future that we are in for. Thank you so much for your time, and I look forward to the panel and the questions later. Thank you.
Thank you, Sumit. Our next participant is expert in medical imaging. His name is Dimitri Amiras, and he's consultant radiologist at Imperial College National Health Service Trust. So, something more about augmented reality.
Good afternoon, everyone. I just want to say thank you very much for taking your time to come to this talk. I do think it is very important, and I'm very humbled by being part of this panel. As great as everyone is on this panel, I would say that the future of medicine is actually the educators in front of us today. So it is a really great honour to talk in front of you guys and try and explain to you what I think 2030 will look like. So just to start the talk, I'm going to talk a little bit of my own self-promotion. This is a paper published recently about using augmented reality in surgery. It's the first presentation of augmented reality in plastic surgery. If you want to see it a bit later, I can show you a demo if you want to come and see me afterwards, but that's all I'm going to talk about that for. I think everyone knows this couple and this family, and this is opposite where I work. So the Lindo wing is part of St Mary's Hospital, which is part of Imperial College Trust, and this is opposite actually the radiology department. So before this was happening, there were a lot of photographers camped out in the radiology department looking out the window trying to take some good photos. The other thing that happened at St Mary's Hospital is this. So Sir Alexander Fleming discovered penicillin. So he did that in 1928. Does anyone know roughly when penicillin was actually used? First started being produced. So it was 1940. It took 12 years to go from the discovery to the production of penicillin, which did change medicine and probably changed the course of World War II as well. So we're in 2018 now, 2030. We're looking at the same sort of time period, 12 years. 12 years was how long it took me to become, from a medical student to become a consultant radiologist. So this is actually a very short space of time in medicine. So when I started thinking about 2030, this is what I thought. And I'll explain to you why. The biggest problem in medicine is socioeconomic forces. Nothing can predict patients getting disease than socioeconomic force. This is going to be a big problem by 2030. And it's not just in the developed countries where there is an increase in inequality, but it's also in developing countries. This is a map produced by the IMF showing it's a map of the Gini coefficient. I'm not a health economics expert, but this is very important to me. And you can see here that there are increases in inequality in the world. And there's a rough distribution of the map there. So as these things continue, we'll be facing harder and harder struggles in the medical field, in the hospitals. We'll be seeing increasing diseases that we wouldn't see before in developed countries. And there are more problems facing developing countries. There is an increase in the elderly, and you can see here this map shows a prediction of what's happening in 2050 and how the world population is getting older. The more red is the increased percentage of the over 60s. And they are a very difficult group and very expensive group to treat. Does anyone know which virus this is? Does everyone recognise it from the Ebola? Yes. Now, the reason I bring up Ebola is because what this really showed the world was that there is a global need for health professionals. I'm not just talking doctors, I'm talking nurses, midwives. In 2015, when the Ebola crisis happened, the African countries had a shortage of doctors. They were running on a very low number of doctors, and actually it was the developed countries that had attracted a lot of their trained doctors to come. So it's a great importance as educators that you try and help and encourage your students or whoever that you know to be interested in medicine, and not just being a doctor, being a nurse, being a midwife, being anything to do with health. We need more doctors. The WHO in 2013 predicted that by 2035 we would need 13 million healthcare professionals. So I cannot stress this enough. Please try and encourage people to go into the healthcare field. It is very, very important. Another crisis we're facing is the increasing sedentary lifestyle of people. We are sitting in the development ward more than we were previously. This is leading to a lot more healthcare effects than we actually really understand, and I think it's important to recognise exercise as a very important medicine itself. But there is hope. My hope for 2030 is that medicine is not just about science, it's not just about technology, that we actually start to embrace the spirituality of medicine as well. We have to recognise there are some things that we cannot change, and that actually what we need to focus on is allowing people to go through the natural passage of life. I think as doctors and as medical professionals, sometimes we struggle to accept the fact that death is a certainty. In Switzerland, we now have the ability to have euthanasia for chronic diseases such as dementia. I think this is a very difficult and ethical subject, but I do hope in 2030 we will be a lot more practical and a lot more understanding of the necessity of life and the fact that death is a real thing. The other thing I want to highlight is the importance of mental health. And I think in the Western world and in developing countries, we don't recognise we don't recognise mental health as an important predictor of actual recovery from health diseases. I'm going to quickly talk about the cost of healthcare. You can just see this was published in 2013. The US is right at the end of the scale there as far as spending money, and what we've used there as an outcome is life expectancy. Now, this just shows you what the other speakers have talked about before, that the healthcare economy and is not sustainable, and if the model needs to change. What is this model? So in 2010, Obamacare was passed as legislation. Part of that was using, very importantly, to change the model. So the model before was about productivity, was about pay for service. Now we're talking about value-based care. How are we going to get there? It's very difficult to talk about computers working out what value-based care is. I think the next important thing for you guys as educators is to try and impress the importance of health on the people, on our patients, on everyone. That people need to be in control of their health. We need to re-empower patients to understand what health is and what's important, so they can then show everyone what the value is. Sorry, it's a very truncated talk. I hope you all appreciated it. If anyone wants to see anything about the HoloLens, just come and grab me afterwards. Thanks.
Thank you, Dimitri. Our next speaker is a young lady with quite a long list of awards and achievements. So I'll mention just a couple of them. Young leader by the World Economic Forum, 30 under 30 US Forbes list, Woman of the Year in the United Kingdom in 2013. And what is even longer than the list of achievements is a list of topics that she can talk about. But so I believe that this is the right time to start talk about the future. So there are some possible roads to the future. Which one would you suggest?
Thank you so much, and I'm humbled by the presentation, and the panel is really impressive today. Thank you for having me. So today, actually yesterday, I gave a presentation here. It was about technologies and disruptive innovation in healthcare. So today we're going to talk about the future. And I think if we haven't envisioned what is the particular target that we want to hit in the future for healthcare, we are not going to hit it. We're not going to make it. So it is hard to measure how much our health has improved over the course of history. But a fairly good indicator is the average life expectancy. So if we think about the evolutionary pressures that shaped the Homo sapiens, he had an average life expectancy of 33 years. And by 2030, we expect the average health expectancy in some countries, not everywhere, to be more than 90 or even 100 years of age. That is a big progress. I'm working in the field of stem cells and regenerative medicine. So we're developing stem cell therapies and artificial organs for transplantations, or for people who want to potentially in the future have the option of biobanking their real extra organs in case they have an accident or in case they want to prolong their life expectancy. So the potential for this technology is immense. In the next 5 years, not in 2030, but just in 5 years from now, we're going to be able to use stem cells to correct chronic autoimmune diseases such as rheumatoid arthritis, multiple sclerosis, colitis, or Crohn's disease and scleroderma. In the next 5 years, 10 years, we think that the next target is going to be neurodegenerative diseases. And we will be able to reverse effects of Parkinson's disease, Alzheimer's disease, or even a stroke. So you will think, that's great, but it's going to be affordable. Well, it may be affordable. At this point, to give you an idea, we've gone from thinking that the cell therapy would cost $100,000 just 10 years ago. And today, the approximation of these therapies are around 10,000. And we think that this is going to be diminished even more in the next 10 years. So we're speaking about the potential of curing chronic diseases and revitalizing particular organs for less than the price of a new laptop. This is quite a change from the past 100 years for sure. So it should be apparent that the field, especially of healthcare, is entering a period of exponential growth. And however, the major drivers are not just technological, just like Dimitri said. As the baby boomers age, there is no amount of money that the richest among them won't spend for a little more of quality time with their loved ones. And thus, every new technology, whether this is artificial organs, whether this is imaging or real-time telemonitoring and surgical surgeries, well, this will be possible for the elitistic, privileged few, but maybe not for everyone. So while the developing world, third world countries, can certainly benefit from several of these technologies because they can be translated into cheaper budgets, they can be manufactured in a nanotechnology way so that they are mobile and affordable. Some of them, they can cure a few of these diseases. The truth of the matter is that the majority of the needs in the third world are still really basic. So they need bed nets and antimalarial drugs, they need antibiotics to combat bronchitis and diarrhea, and they need even just plain education to familiarize themselves with the realities of HIV and the necessities even of just contraception. And ultimately, meeting the medical needs of the entire world means empowering the rising billions with the basic resources like food, water, energy, education, while at the same time find a way to also invest on breakthroughs and disruptive innovation in healthcare. So I won't elaborate again on what particular technologies that I also work on, like bioengineering and artificial organs or gene editing, are going to do in the possible future. Instead, because I told you, I think the most important thing is all of us to have a consensus about what future do we really want, what type of healthcare do we really want by 2030. I will just give you 3 examples of what 2030 may look like. So let's pretend that it's 2030 today. And the first scenario is that your healthcare is just your own responsibility. So it depends completely upon the salary that you are getting, and that's it. There is no guarantee that any government or any other social network is going to help you cure yourself or have access to any type of healthcare. So the cost of, in this reality, the cost of providing healthcare to aging populations with complex and chronic health needs has been rising steadily for many years, and that's how we got there. For well over a decade, from 2020 to 2030, health systems warned that there's going to be a breaking point and needed radical and saving surgery on their own, but this cannot be afforded. We can see this in many countries already, for example, Greece, or even the NHS that is in major debt. And there was a marked drop in the number of people entering the labor market. So there are so many people that don't have even jobs, and they cannot basically give money to the current schemes within the local governments to support, the ministries of health. So the life expectancy means that the growing numbers of older and frailer people also are higher in order to support. So therefore, the governments decided that the best way forward is to leave the healthcare insurances upon the people themselves. The second future that may happen is that your health depends upon the country that you're living in. So it depends upon the regulations that your own country has. And this means big moves of population from one country to another, depending upon the quality of life that you can have there. A guaranteed basic income for all citizens could be a reality. This could be different in many different countries. And local level responsibility for services and initiatives that enhance and equalize life satisfaction and foster community development may unlock new resources and new capabilities for these particular citizens. So how did we get in that phase? So widening inequalities in wealth and social mobility and health has been persistent trends. The governments could not agree between them in having a unified healthcare policy. We can see this already, at least I'm coming from Europe, and the healthcare systems are extremely fragmented between different member states. It is a completely different reality and different treatments that you can get if you are having cancer in Greece or if you're having cancer in Germany or in the UK. And this is something that we see already, and it will become even more apparent in this second scenario. So as large-scale wealth redistribution was very challenging politically, the politicians were not willing to take the risks, and they believed that the best case is to have a completely different economical and healthcare system in every country that will not share its treatments from one place to the other. So therefore, medical tourism will not be allowed anymore. There is not going to be a way for a woman that may be, for example, pregnant in a neighboring country to deliver her baby there. She will have to go back to her native country to do that, and for every other patient as well. It's not extreme if you really think about it, and I'm sure many of you are thinking that this is very close to the reality that many of our countries have already. So the third scenario that I want to discuss is the scenario where technology delivers. So it's the scenario where your health depends on your access to technology. And what this means is that the governments have decided that in order to diminish inequalities, the best case scenario is to provide access, first of all, to information technology to everyone. So everybody can have access to educate himself about different diseases and have preventive medicine information, but also artificial intelligence and robotic systems, mobile clinics with telemedicine have been the primary investment of the world, not just from every country, but as a unified healthcare system. Therefore, even if you are in Africa, even if you're in Greece, even if you are in the United States, you will have the same amount of information, the same exact information, and depending upon what type of treatment or intervention you may need, there will be an international legislation where you will be transferred to the appropriate place so that you have the best quality of care. So this might happen again because the time. So my final thought, since we don't have a lot of time, is that as you realize, healthcare delivery is a very complicated, multifactorial problem. And it is not easy to just have together, for example, in a panel like today, a bunch of scientists or physicians to explain what are the breakthroughs of healthcare. In reality, we cannot solve such a multifactorial problem just by having expertise only in healthcare. And that's because other problems like environmental factors, the pollution, or different things in your everyday life, the lifestyle of your work, and even the possibilities of having access to different things in your life affect completely your health, your mental health, and also your physical health. So in order to decide what is the best future and how we're going to get there, what do we envision, what we would like to achieve by 2030, we have to bring together ministers, politicians, key stakeholders from all sectors, from the environment, from manufacturing, from every type of different aspect of our life in order to fix something so critical as healthcare for all citizens. And I would like to see more panels to be more diverse and having people from other sections talking about why healthcare is our priority no matter what we're doing in our lives. Thank you.
Thank you. So between now and 2030, we have to make some decisions, and we are trying to base it on scientific evidences, on current practice, political issues. So I would like to pose this complex issue to our next participants, Dame Mary Archer, who is Chair of Advisory Board of Center for Personalized Medicine, Oxford University.
Thank you very much, Mr. Chairman. And I too would like to thank the Varkey Foundation for the invitation to come to this extraordinary conference and for the opportunity to speak today on the subject of medicine and human health in 2030. They say a week is a long time in politics, and certainly it can be, with the changeable wind of events blowing even the canniest of strategic planners off course. But if a week is a long time in politics, 10 years is a very long time in modern medicine. By 2030, 1/3 of what is taught to medical students now will be thought wrong and outdated and have been changed. Artificial intelligence, augmented reality will routinely assist the diagnosis of disease. New antibiotics will have been discovered, I'm sure of that, and I'm equally sure that pathogens will evolve to stay one step ahead of them. Telemedicine will supplement face-to-face healthcare delivery, as Bassem Hashash has told us. Minimally invasive surgery will be consigning open surgery to the history books. We will have learnt smarter ways of coexisting with our many non-communicable diseases, such as cancer and diabetes. The increase in global population and continuing waves of displaced persons will continue to put great strain on all public health systems. And finally, we will, on average, be fatter. So, a mixed report on health status in 2030. But one aspect of healthcare will certainly have been transformed for the better, and that is our ability, as we've heard today, to diagnose the root cause of many diseases and to design effective treatments for them. And this will have been transformed by developments in genomics, informatics, regenerative medicine, and bio-nanotechnology. In 2030 and beyond, genomics and GWAS, genome-wide association studies, will allow us to search somatic and tumor genomes ever more cheaply and quickly to find telltale mistakes, as Sumit Jamuar told us. Informatics will enable this enormous cascade of data to be interpreted. Regenerative medicine will deliver cell-based therapies for repairing damaged tissues and even growing new organs, as Eleni told us. And finally, bio-nanotechnology will deliver drugs and other interventions exactly where they are needed in the body, instead of spraying it all around and causing all kinds of systemic side effects. Where has this revolution come from? If we look back in history, as Simon Sharma encouraged us to do in his marvelous plenary yesterday, we find the practice of medicine rooted in empirical treatments, some of them effective, others, like bloodletting, not so. The highly effective use of willow bark extracts to reduce pain and fever dates back to the earliest known civilizations. But it wasn't until the late 19th century that chemists, such as myself, developed an understanding of molecular structure to the point where in 1899, the German pharmaceutical company Bayer could synthesize acetyl salicylic acid and market it as aspirin, a highly effective drug still in use today. Fast forward half a century, and we encounter the era of so-called evidence-based medicine, where the best therapy for a particular disease is based on a number of randomized controlled trials conducted according to rigorous and agreed protocols. The birth of the gold standard double-blinded randomized controlled trial is typically dated to a 1948 evaluation by the British Medical Research Council of the use of streptomycin for the treatment of tuberculosis, although there's a much longer history of efforts to empirically assess experimental therapies. Way back in 1753, the Scottish surgeon James Lind published a controlled trial showing that a diet including citrus fruit protected sailors at sea against scurvy. This approach of evidence-based medicine is still the norm in most of Western medicine. When I was diagnosed with bladder cancer 7 years ago, I was given a course of BCG, Bacillus calmette-guérin, which the evidence base showed was effective for 80% of patients with my grade and stage of disease. Unfortunately, I was not in that 80%, and it didn't work for me. And I went on to have an open radical cystectomy, one of those large holes for a large operation. But I was in Cambridge, fortunate to be so, chairman of the hospital in which I was given a very nice new bladder made out of 1/2 meter of my small intestine. And now evidence-based medicine is yielding, or rather the nature of the evidence on which treatment is changing, but thanks to the developments in the areas I've mentioned: genomics, informatics, regenerative medicine, and biotechnology, bio-nanotechnology, are coming together to create the new era of personalized medicine, also known, of course, as stratified or precision medicine. So instead of the current blockbuster approach, where all patients with the same condition receive the same first-line treatment, even though, as we've heard, it's only on average about 40% effective, we are seeing the advent of personalized medicine based on the comprehensive genomic characterization of each one of us. Thus, by 2030, my prediction is we shall see whole genome sequencing as a matter of routine for a considerable number of specific conditions, and comprehensive linkage of diagnostic data with informatics to give better outcomes for patients. Thank you very much for your attention.
Thank you. Since we don't have much time, I'm leaving the floor for your questions immediately. please. Just give us your name.
My name is Viet. Easy to remember, Viet from Vietnam.
Okay, thank you.
Trainer. I talk about skill training and how to. I'm training for disabilities. No, I'm training. Sorry, and especially for children with autism, especially teenagers with autism. But I don't use don't use medicine, no pain, and they want to shift. But it's based on genetic, but not genetic, but epigenetic, epigenome. It's from ego to eco, ecosystem, and especially social ecosystem. And our stem cell, when duplicate, then regenerate and replace, it stem cell epigenome and epigenetic, 80% influence on the process of stem cell regeneration, stem cell duplicate. It means we need soft skill training. Soft skill is soft power. You make life healthy and wealthy. It training more. It only mention it too difficult. And because this for which skill training, I think a little bit next time, like you say, once soft skill training, soft power for healthy and wealthy life. No stress, no depress, and no issue.
Would you like to pose concrete question to our participants?
No, that's a share. And it's a little bit more about not genetic, more about epigenetic, not about more about ecosystem
Thank you.
and social ecosystem to make healthy and wealthy life.
Thank you, Viet. Do we have another question? Sir, in the second row. So your hand was first.
So there's a Mike Butcher from TechCrunch. There's quite a lot to take on there, but quite clearly, you know, most of the speakers seem to be projecting forward into the future, sometimes fairly near future. There is obviously clearly some practical applications of virtual reality in medicine and in surgery, for instance. There's some obviously great leaps being afforded in areas like genomics and CRISPR, the use of CRISPR and things. What sort of timelines, though, does the panel, and this is for anybody really, what sort of timelines are we working on here? Are we looking at a sort of an exponential growth in the ability to apply these really sort of very far-reaching technologies, or is it going to be sort of a gradual improvement? Medicine and, let's be honest, medicine and pharmacology, my father was a malaria research scientist, have been, it's taken a long time to get where we are. And you said earlier to Sir about, it took 12 years from penicillin to go from in the laboratory to application. And are we seeing an exponential growth of this, or is it going to be just a gradual improvement?
I can take that. Mike, hi, is it working? Let me start with the response, but I think, I defer to some of the other panelists on certain aspects. So, Mike, that's what's so exciting about this whole opportunity, that it is going exponential. So if you think about the first human genome was sequenced in 2003, already 14 years hence, or 15 years hence, we are seeing so many developments in terms of, there was a statistics in 2015, almost 45% of all drugs which were under development were using some form of genomics. We already know that the success rate of developing therapeutics, which is actually pretty low, if historically it's been like over 90% of any molecule which go into a trial fail. When you add genomics and biomarkers, that success rate changes to 26%, which is 3 times more. So we are seeing those changes which are happening. The second thing which we're changing is we're seeing use cases, right? So as people have more success, we now understand how you use technology, and there are new cases being developed across the frontier. what that helps is once you have success, people are investing more and more money in terms of making things happen. And so as a society, the fact that, if I look at Singapore adopting apps in terms of the way the clinic will be run, it is changing behavior. It is the same behavior change that mobile phones brought into our lives, from landline to mobile. It changed the behavior. People are getting used to it. So I would say there's a lot happening now. But if you think about 15 years, this is where the exponential increase and the changes will come into place. At that point, I'd like to defer to some of the other panelists as well for if they have any views.
Thank you. So, since we are very short, actually we don't have time, but I will think they will tolerate one short question more. So, since you had a question,
thank you.
Please.
My name is Catherine from Kenya, South Africa, and I want to appreciate the presentation from our panelists. And following the presentations keenly with a lot of interest, I'll sought for clarification. Like from all that I've heard, I know with the developing world and the low economies, we are struggling with our communicable diseases and realizing what technology has. So my question was, what do the world have for those of us from the other side? We are now on genomics, where we are on nano, whatever, biotechnology. And the other side are realizing that, I know, it will pull back our efforts as human race to come to the same level. So I was asking Eleni, she gave a good presentation on the three aspects, that 2030 will be determined by three aspects: where you are, and the decisions that I've made, and the digital world. So I was just requesting, what do we have for Africa and the developing economies, especially the panelists, so that I'm at policy level from my country. Thank you.
So I agree with your comment, you're right. We cannot move forward if half of us are staying behind. And this is a decision that we have to take synergistically wherever we're living in the world. There has been a positive trend in the past 20 years, and that is from individuals that are wealthy enough. Even, for example, we're talking about philanthropic entrepreneurs. Bill Gates and the Melinda Gates Foundation is doing a lot in Africa as well, and so many other people that are in the top 5%. They are trying to help these regions. But are the governments doing enough? And are the citizens of the world concerned enough with what is happening in their neighbors? This is something that is also a moral issue. Have we instigated this sense of urgency for the well-being of everyone in the world?
in the same way that we care about ourselves and our families, I don't think we have done enough. This is the education forum, and I think this is a key message that I want to give to all of you, that part of the education is making everybody aware and compassionate for the well-being of everybody else. And healthcare shouldn't be something that you have to fight for. It should be a right, no matter where you're living. And definitely we're not doing enough for Africa. There has been, for me, I want to stay optimistic, and I'm a stubborn optimist. Like I will say that all these technologies, some of them are really too complicated to be transferred in a setting where basic hospital settings do not even exist. But let's think about some of these technologies, like for example, lab on the chip.
You may have heard it's a miniaturized technology where you can give one drop of blood and have diagnostics for so many different diseases. This is something that is happening in the United States and in Europe, and we're transferring this technology so that it's mobile and accessible in places that they don't have infrastructure to do this type of diagnostics. So I do think that we should pressure the governments that are in the advanced world to invest more in technologies like this so that we can bring everybody forward. You're very right. Thank you.
Thank you for your questions. We had really inspiring talks, and I'm asking you for a warm applause for our participants. Thank you all. So we shall continue with the other discussions.
Thank you.
Thank you very much.